So thanks, Dr. DeMax. I am Jim Young. I'm from the Cleveland Clinic, obviously in Cleveland, Ohio, not Cleveland, Texas, just north of Houston. Not Cleveland, Texas, just north of Houston. I'd like to get my colleagues up to the table so that I could introduce them and kick things off. It was a very stimulating, I think, introduction to the afternoon. This is the second session. We'll shoot for termination of it somewhere around 3:15. We're pretty much on time right now. But this particular session is geared towards four very interesting examples of the issues that Dr. Horowitz and Lauer raised in the first session. And they're interesting to me personally, having been very heavily involved with the HOPE trial and seeing its emergence and its successes and its failures and its frustrations, and then not knowing anything about the other trials that are going to be discussed and the other efforts. I think it will perfectly set the stage for what the conference organizers are trying to do. Specifically to highlight four examples of LSTs that exemplify different defining characteristics. And you've already heard one allusion to one of the issues, the placebo question that came up. To see and talk a little bit about trade-offs in trial design by discussing pros and cons, giving examples of how these might play out. And again, I don't want to beat a dead horse, but looking at this issue of placebos is right on target there. And then to foreshadow the rest of the workshop by asking the example speakers to address their own personal views on the successes and failures. I'm going to quickly, briefly introduce the four speakers. Next to me, as you've already heard from her question and comment before, Professor Joanne Manson is Chief of the Division of Preventive Medicine at Brigham and Women's, and the Michael and Lee Bell Professor of Women's Health at Harvard Medical School. She's an endocrinologist, an epidemiologist, and an expert in preventive medicine. I like the fact that you're an endocrinologist. I have an odd job at the clinic in that I'm a cardiologist, but I run our Endocrinology and Metabolism Institute for unusual reasons. We have Nitesh Chowdhury, who's an associate professor at Harvard Medical School, an associate physician in the Division of Pharmacoepidemiology and Pharmacoeconomics, and the hospitalist program at Brigham and Women's Hospital. He's an internist and health services researcher. And then our third speaker will be Elsie Tavares, an associate professor of population medicine at Harvard Medical School and an associate professor of pediatrics at Children's Hospital in Boston. He's the co-director of the obesity prevention program in the Department of Population Medicine. And one of the reasons that I'm a pseudo-endocrinologist is we have bariatric surgery in our Endocrinology and Metabolism Institute, and a huge focus on both adolescent and adult obesity. So I'm going to be anxious to hear about that particular trial you will be discussing more. And then Dr. Devereaux is an associate professor in the Department of Clinical Epidemiology and Biostatistics at McMaster University up north with several of my old HOPE and CHARM friends. He has conducted the world's largest cardiac randomized controlled trial in patients undergoing non-cardiac surgery. He was the co-PI of POISE-1 and is currently the PI of the VISION study that's evaluating major vascular complications in a representative sample of some 40,000 patients undergoing non-cardiac surgery in 14 centers in 10 countries. Quite a magnificent effort. So we're going to start with Joanne. I'm going to ask her to take the podium and remind all the speakers that there's 10 minutes to your presentation so that we can generate some more conversation at the end. And I've been told that the flashing lights there will tell you when you're in trouble, yellow, and when you're in deep trouble, red. Thank you.
Well, thank you so much, Dr. Young. It's really a pleasure to be here and a pleasure to participate in this important workshop. It's an honor to be able to tell you about the vitamin D and omega-3 trial, which is an example of a large, simple trial. I'd like to comment that I don't have any financial conflicts of interest. The vitamin D and omega-3 trial is NIH-sponsored, primary funding from National Cancer Institute and National Heart, Lung, and Blood Institute, a secondary sponsor, Office of Dietary Supplements, and several other institutes and agencies. Before I begin on the vitamin D and omega-3 trial, I want to comment that the overall design of large, simple, male-based trials that are classical design in terms of placebo-controlled and getting medical record confirmation of outcomes are actually not new. There are many randomized trials. It's unclear why this hasn't been adopted more widely for many types of interventions, aspirin, nutritional supplements, even medications, some medications, and also behavioral interventions, and especially now where you might use a mobile device to remind people to do certain behavioral changes. There are many opportunities for doing these large, simple, randomized trials. So some examples, and these specific examples on this slide are large trials that were done in health professional populations, again, with placebo controls, and they've provided answers that are very similar to trials that cost 10 times as much. The Physicians' Health Study testing aspirin and beta-carotene finding a significant reduction with aspirin of a first MI in men. The Physicians' Health Study 2, we just reported the results with multivitamins and a significant reduction in cancer. Also vitamin E, vitamin C, which were null findings. The Women's Health Study, significant reduction in stroke with aspirin, and vitamin E was a null result. The Women's Antioxidant Folic Acid Study tested. These are factorial designs, by the way, so looking at the independent effect as well as potential additive or synergistic effects of these agents, beta-carotene, vitamin C, vitamin E, folic acid, B6, B12. So as I mentioned, these are health professional populations, involve placebo control, mailed calendar packs to remind people to take their pills, very high compliance rates, baseline blood collections in these trials, and about 70% of participants, follow-up bloods in a sample, medical record confirmation of endpoints, national death index, in addition for mortality follow-up. These trials are highly cost-effective, and there are many other examples of such trials, but probably not as many as there could be. On average, they're about $100 to $200 per participant per year in direct costs, and then if you take into account the factorial design and multiple interventions, you're often talking about only $50 to $100 per intervention tested. So this is definitely a very cost-effective approach to doing prevention research. We've been focusing a little more on treatment trials, but these are prevention trials, usually cardiovascular disease prevention, but also cancer prevention in midlife to older individuals. This is just a picture of a calendar pack that was used in the Physicians' Health Study. You can see that 31-day pack reminds people to take their pills. Even 3 pills. This is 3 pills one day, 2 pills on the other day, because the vitamin E was given every other day. So a fairly complex regimen would be difficult to do with bottles, can be done very easily with a calendar pack, also facilitates reporting of compliance. So these calendar packs can be mailed 6 months at a time or 12 months at a time, and again are very cost effective. So now what's different about VITAL is that it's a usual, typical US population, very representative of the US population, not health professionals. So the rationale for the trial is the emerging evidence that vitamin D and the marine omega-3s, EPA, DHA, reduce risk of cancer and cardiovascular disease, the increased use of these supplements in the population, underscoring the need for a conclusive evidence. And actually, despite very frequent use of both vitamin D supplements and omega-3 fish oil and primary prevention, there haven't been previous large-scale randomized trials of these agents in primary prevention of cancer and CVD. So the aims are to test each agent individually, the vitamin D in reducing total cancer and major CVD events, a composite of MI, stroke, CVD, death. The same for EPA, and the secondary aims to look at site-specific cancers and an expanded outcome, cardiovascular disease outcome, as well as individual components of the CVD outcome. As I'll show you with this trial that will be 20,000 individuals, there's excellent power, more than 90% projected power to detect 10 to 15% reductions in the primary outcomes. This slide shows the overall design of the VITAL trial. So 20,000 initially healthy. It's a primary prevention trial, men and women, men 50 and older, women 55 and older. So the age groups where risks of chronic disease begin to increase. The factorial design is shown on the slide, vitamin D3, 2,000 IUs a day versus placebo, given in a calendar pack that's mailed to the participants. Nationwide recruitment throughout the entire United States. And then further randomization to EPA DHA. So there, as you can see, 4 different treatment groups. Mean treatment period, 5 years. Baseline blood collection in about 16,000 and follow-up bloods in 6,000, so that we can look at effect modification by baseline blood level and by baseline parameters, as well as look at change in blood level and change in biomarkers in up to 6,000 individuals. As I mentioned, primary outcome cancer and CVD. The eligibility criteria, this is a highly representative study population with very few exclusions. So men 50 and older, women 55 and older, because it's primary prevention, no prior history of cancer except non-melanoma skin cancer or prior CVD events such as MI, stroke, or coronary revascularization. We do exclude for history of renal failure or dialysis because very often people are on other medications that can interfere. No prior history of hypercalcemia for safety reasons, severe liver disease or sarcoid TB, other granulomatous conditions. That is for safety reasons because there's a small percentage of the population that can synthesize 1,25-dihydroxy vitamin D from cholecalciferol. No allergy to fish. All of these exclusions lead to excluding no more than about 10% of the midlife to older age U.S. population. Where we are seeing a few more exclusions, about 25, 30%, is that many people are so convinced of the health benefits of vitamin D and fish oil that they want to continue taking. They want to take supplements on their own, and they won't agree to be randomized. It's interesting how many people say, but is it, I'll be in the trial as long as I can be randomized to the active vitamin D or fish oil. So we have a goal of having good racial ethnic diversity, about 5,000 Black, African American, and Hispanic, and this is the breakdown of other groups to make it fairly representative, and about 50% men and women. Where we are now, we're almost done with recruitment. We've actually been randomizing only since last November, so in about 12 months, we're now close to 19,000 randomized. And again, this has been very cost-effective, population-based nationwide mailings, targeted, as well as some targeted mailings. We've had a lot of media reports where there's been interest in the media in the trial, so when they've often provided the website address and a 1-800 number, which has led to a lot of people calling to be in the trial. Some advertising, radio and print, placing study-related brochures in health centers. And then what is definitely the major challenge of a male-based trial, but I think randomized trials in general, is the racial ethnic diversity and really achieving that. But we've done quite well. Targeted minority enriched mailings, including alumni of historically Black colleges and universities, community health center collaborations, church bulletins, and collaborations with investigators in some large urban areas. It's been really gratifying to us that we've been able to get funding for several ancillary studies, which will really help to increase the yield of the study and advancing our knowledge about vitamin D and omega-3s. So, for example, we have an ancillary study on cognitive function from the National Institute on Aging, diabetes, glucose tolerance, NIDDK, and a number of others, hypertension, autoimmune disorders, lung diseases, diabetic kidney disease, fractures, bone imaging, mood disorders, infections, 2D echo, and down the line. We also have under review grants on vitamin D genomics and other outcomes to look at that personalized aspect of, are there some subgroups that benefit more than others based on underlying genetic factors, for example. It's a hybrid design with 1,000 participants coming in for in-depth phenotyping in a clinical setting, making use of the CTSAs, the Boston area, so blood pressure measurements, anthropometric measurements, a urine collection, a 2-hour oral glucose tolerance test, spirometry, physical performance testing, detailed cognitive function and mood, depression testing, 2D echo, and then DEXA scans and bone microarchitecture. The current status is, the latest report is more than 19,000 randomized. We're actually going to end up overshooting our recruitment goal, closer to 23,000, based on those in the pipeline. About 70% have provided baseline blood collection. There are some agencies you can work with, such as Examination Management Services, Inc., to help collect, do even home visits to help collect blood samples in nationwide trials. It's a very useful resource. We do expect to achieve the demographic recruitment goals. 1-year follow-up has begun for those who were enrolled early. It's a staggered recruitment. Compliance is excellent. I mentioned ancillary studies have received funding, and the in-clinic visits are on track to meet those goals. So in conclusion, this is a trial that is testing 2 promising interventions, vitamin D and omega-3s, for prevention of cancer, CVD, and some other chronic diseases. Conclusive evidence is lacking, and we do think that given the design, that VITAL should be able to answer conclusively. No one trial will be the final word, but it will be able to provide very meaningful results in terms of the role of these interventions in preventing cancer and cardiovascular disease. If you're interested in more data, more information, that's the study website, vitalstudy.org. Thank you very much.
Thanks. Thanks, Joanne. We'll move on to the next presentation, wrapping up all of the discussion after you've heard all 4. So you saw one example of an ongoing trial that has not yet concluded. To give us an answer, we'll talk about another trial which has concluded and deals with the issue of waiving medication copayments for improving drug adherence and health outcomes. The post-myocardial infarction free RX event and economic evaluation, or the MI-free, or do you say MIFRE trial?
MI-free is how we go. So this is a very different kind of trial. So I'm going to present, I'm a health services researcher. I focus most of my time thinking about medication adherence and improving prescribing in the post-marketing setting. And this was a trial that we did in partnership with Aetna. And I'm going to describe the basic structure of the trial. I think in the information packages there's a little more information, but focus the last kind of 5 to 6 minutes of my commentary really on what we learned from doing this and kind of what I see as the methodological challenges. So just by way of context to catch everybody up to the world that I live in most of the time, adherence to chronic disease medications, and in this case post-MI medications, is appallingly bad. So within 2 years of starting therapy or having an event, numerous studies conducted by people in this room and elsewhere really demonstrate that half of patients remain adherent to these evidence-based therapies. And this has, of course, as you would expect, profound clinical and economic consequences. There are lots of reasons. Non-adherence, just like most health behaviors, are complex. And drug costs and the amount that patients pay out of pocket is a consistently observed factor. And this is true even for people with drug insurance. So even small changes in copayments lead to substantial reductions in medication adherence. So this idea of eliminating out-of-pocket costs for evidence-based therapies has been touted for the last decade or so, and it's sometimes called value-based insurance design or evidence-based plan design. And there have been observational studies suggesting that it might be a good idea. But at the time that we initiated this study, there lacked any sort of randomized evidence that not only evaluated changes in targeted medication use, but also sought to answer what happens to clinical outcomes as a consequence of changing health benefits. So the basic design of this trial, the design was published a few years ago, there's a reference at the bottom, was to take Aetna beneficiaries who were discharged from hospital after an acute MI. So this was a completely, in a way, remote automated trial. We identified patients using claims-based algorithms that flowed naturally from hospitals into insurance companies. And we applied a validated algorithm for acute MI care, which has a specificity of around 99%. So we did this on a every 2-week basis to identify newly eligible individuals. We also used the claims to exclude individuals who would be potentially ineligible, some for curious reasons. For example, the elderly. It was illegal, as I learned, through the threat of jail for us to randomize Medicare beneficiaries, so I decided not to do that. But in addition, there were, of course, a few other people who had benefits which were relatively generous at the time. And then we cluster randomized by plan sponsor. So plan sponsor isn't the entity that's responsible for an individual's health benefits. Their employer, in general terms, union, other sort of entity like that. And we randomized to 2 groups. Very simple trial in its intent, which providing full coverage to all of the cocktail of post-MI, standard post-MI medications, ACE inhibitors, beta blockers, ARBs, and statins, or to usual level of insurance coverage. So this was a trial which was a policy trial. All we did was change insurance coverage. And we contacted patients using EMSI, as it turns out, one time, by mail and by phone in both groups. They got a call saying, "We're sorry you had a heart attack. Your doctor may have prescribed you medications. It's really important that you take those medications." And the intervention group got the additional sort of note that, we think it's so important that you take these medications that we're eliminating cost sharing for them. And what we did was then change authorization codes so that when they went to the pharmacy, just like all of us who go to the pharmacy, our claims are instantly adjudicated. Those were changed so the next time they went to the pharmacy or called up their mail order, they had no copays for those medications, no cost sharing, no contributions to deductibles. That's it. There was no other intervention, one-time contact, and leveraging the existing system of pharmacy adjudication. All prescribing decisions and which drugs, generics, brands, whatever, were left to the discretion of patients and their physicians. So the idea in the large, simple framework, really we randomized plan sponsors rather than individuals, and this avoided what we call the water cooler problem, where if 2 of us were employees of the same corporation, we showed up at the water cooler and said, "Hey, I just had a heart attack and I get my drugs for free." And you said, "Hey, I had a heart attack and I don't," you might be upset by that. And so this avoided some of the practicalities of that. It also avoided the need for patient-level consent, since what we were doing here was providing more generous coverage to one group and usual insurance benefits, and employers can change insurance as they see fit on a general basis. With this system also allowed us to do what would be typical in randomized trials, which is randomized within blocks. And so this method didn't prevent some of the more rigorous design choices that are often made. In the large, simple framework, we also evaluated outcomes using health services techniques. So we evaluated outcomes using claims as well. We didn't collect data specifically for the study in any other way. And we focused on clinical outcomes to answer the "so what" question, but focused on the outcomes which are presented here. Our primary outcomes were major cardiovascular events, which means rehospitalization for MI, unstable angina, heart failure, or stroke, or revascularization, as in percutaneous coronary intervention or CABG. And then we had a couple of secondary, just a few pre-specified secondary clinical outcomes. For the purpose of the results that I'm about to show you, we focused on those outcomes that were verifiable, as in claims-based in-hospital events, and are using National Death Index data to do sort of follow-up outpatient analyses as well. I'm just going to run through a few of the results and then get to kind of the more methodological meat. So we found these were the classes of medications that we studied. And the red bars are the full coverage group, the intervention group. The blue bars are the usual coverage group. And leaving aside the fact that even the red bars aren't that high, as in adherence was abominable even after doing this, there was an improvement across all of these groups because of the intervention. And this resulted in reductions in major vascular events in the order of magnitude that Dr. Horwitz was talking about, the 1 to 2 percentage points. So if we focus here, this is our pre-specified primary outcome, which was this combination of major vascular events or revascularization. And we saw a reduction, but that was not statistically significant. When we took out revascularization, which we had pre-specified, as you know, revascularization can be a little bit of a discretionary tool these days. And when we took that out, we see this 14% relative reduction. So this small improvement in adherence led to reduction in major clinical events. And similarly, we saw reductions in spending. So at the top here are the top groups of bars here are patient spending, and the bottom groups are patient plus insurer spending. And this is just the cardiovascular spending. And of course, we gave away drugs for free, so pharmacy spending went down, but also patient spending on other things went down, as in they didn't go to the doctor, they didn't have to be hospitalized, they didn't have ambulance visits. And so patients in the cardiovascular realm ended up saving about $400 out of their own pockets over the course of the year. And this translated into almost significant reductions in total spending, which is, of course, driven by the insurers. So from a research and experience kind of perspective, there's a lot of things about this trial which have informed the trials that we're doing now in the same space. So the first is that we use claims to identify patients. And claims, of course, have to flow from hospitals to insurers, and this in itself induces a lag. And it's resource intensive to sort of on a daily basis churn trillions of claims to find potentially eligible individuals. And so we did this on a Q2 weekly basis. And even after this process, you need to go through the exercise. So we managed to randomize people with a mean of 49 days after their MI, which in relative terms was better than what we had anticipated, but it's 49 days. And so to the extent that there's an intervention that needs to be done within a couple of days, this system may be a little bit challenging. Despite the fact that we dealt with one of the largest health insurers in the country, sample size is always an issue, even in large, simple randomized trials. So this was a trial of about 6,000 people. It took us more than 3 years to recruit that number of people. And there were a variety of reasons. So plan sponsors may have to consent here. And we used an opt-out approach in which Aetna said to the beneficiaries, we're going to be doing this. Let us know if you don't want to play. But some people were unwilling to experiment. And so this required Aetna to be willing to say that, which sometimes health insurers may be reluctant. But nevertheless, this threatened sample size a little bit. You know, multi-payer collaboratives thinking sort of globally about how to do this may be a way forward. There's insurance churn, which happens in regular markets. So sometimes 15 to 20% of employers or patients will change insurance coverage every year. They lose their job. And this could certainly undermine sample size and statistical power, and even patient willingness to consent. We were doing a trial in the structure of an insurance system, and I don't open my mail from insurance companies, and I'm sure that most of you don't either. And we all have this sort of, perhaps sometimes fair, perhaps not, bias against them, and so doing trials in this context may have some potential issues there. There are lots of other things that happen in the real world, and co-intervention is a particularly relevant issue here. Although randomization helps deal with this. So in the usual course of things, benefit design changes, open enrollment, things like coverage changes for preventative care, formulary shifts, disease management programs, there's all kinds of things out there in the real world. And while that's a strength, it also is clearly a validity issue. And we address this through randomization, but there's other strategies that may be of potential use as well. And my last sort of slide is that, I think there are lessons from this. There's a clear sort of idea here that this trial, which has informed our other research, really demonstrates the ability to conduct clinically and policy relevant studies in a real world setting. And we're doing other stuff in the same space. We have several large-scale trials that focus on improving adherence. But you could think about the same structure to do all kinds of other things. Other post-marketing comparative effectiveness or safety studies, or even primary efficacy studies could be done leveraging the same system. It's gratifying to me personally that Aetna will actually be implementing the strategy as of January 1st, which, if nothing else, in the context of what we're talking about, really sort of sets the stage for the idea that payers, people who are actually listening to what we're saying, will take the results of a large, simple trial here, in this case, a policy trial, and make it reality. Thank you.
Thanks, Hitesh. So the third example of an LST of success will be presented by Dr. Taveras, a cluster randomized trial involving pediatric patients and the utilization of an electronic health record and decision support tools for obesity intervention.
Thank you, and thanks for inviting me. I appreciate the comment from my pediatric colleague about the large and what large means in some pediatric trials. As you'll see, if I can get my channels up, ours is a simple trial, and I'm actually going to present two trials. But the large in pediatrics is a bit sometimes debatable, what consists of or what large means. So I really want to focus my talk. It's going to be a bit different because I want to give you two examples of how we've utilized and leveraged the electronic health record in a large healthcare system for the conduct of two simple cluster randomized controlled trials. And in doing that, and with some lessons learned, as Nitish did as well, pros and cons, risks and trade-offs, and stakeholder engagement. Our main research partnership, so I sit within the Harvard Pilgrim Healthcare Institute. Our main research partnership is with Harvard Vanguard Medical Associates, and the two used to be married. A few years ago, or actually more than a decade ago, they got a divorce. And so Harvard Vanguard Medical Associates is now a large healthcare system that used to only take patients that were insured by Harvard Community Health Plan. Those of you in Boston know the different names of Harvard Community Health Plan, which is now Harvard Pilgrim. Harvard Pilgrim patients receive their care at Harvard Vanguard, and after that divorce, Harvard Vanguard is now on its own. But it's an amazing group practice. It's a multi-specialty, multi-site group practice. It has about 14 locations across eastern Massachusetts. Now cares for all members of all insurance plans. And I think one of the most important things for the type of research that I do is that it's had an electronic medical record system, EPIC. It's had an evolution of different electronic health record systems. The most recent one is EPIC, but it's had an electronic health record since 1969. And from those electronic health records, we can get information as an obesity researcher of importance is height, weight, anthropometric, other anthropometric data that are coded fields, demographics, lab values, utilization data, and appointments. And as I convince my colleagues who are switching from paper records to electronic health records, it's a bit of some growing pains, but once you do have it and you've implemented it, it's an amazing resource. So the focus of today is really on interventions, and I'm going to be talking about how we've used the electronic health record for identification of eligible participants, for delivery of interventions, and assessment of outcomes. But I just want to quickly mention that, you know, if I'm not already a cheerleader for the use of electronic health records, this slide says it all. And we really have used the electronic health record, not just in this health system, but in the HMO research network that Harvard Pilgrim is part of, to do surveillance. We've looked at obesity trends in defined populations. We've linked children in a large health system like Harvard Vanguard with their mothers and are able to look at pregnancy and its relationship to obesity outcomes in their offspring. We'll talk about interventions. We've also used the electronic health record with some new quality improvement methods to improve the self-reported data on race ethnicity to look at health disparities and assessing the differential effects of interventions, and more started to do dissemination of the work that we've done in EPIC to other practices that also have the same electronic health record. So I am a big cheerleader for the use of EHRs, and that'll come through as I talk to you about the interventions that I'm part of. So I'm going to talk a little bit less about the details of the interventions, because what I want to talk about is the use of the EHRs in these two interventions and how we've leveraged them. And in so doing, I'll talk about the High Five for Kids trial, which is a completed NICHD-funded R01, primary care-based intervention to prevent obesity among preschool-age children. And this was an intervention of children 2 to 6 years of age. And our ongoing trial, the STAR study, this is for 6 to 12-year-olds, so we went for an American Idol type logo there for the to appeal to the 6 to 12-year-olds. But this was from the Office of Planning and Evaluation and R18 in 14 practices of Harvard Vanguard. And to give you just a few more details of the two trials, so they're both cluster randomized controlled trials. High Five for Kids was 2 to 6-year-olds, STAR is 6 to 12-year-olds. We did High Five in 10 pediatric practices. We had about 500 participants. It was 2 years in duration. And it involved restructuring of the care that was being delivered for children who were overweight and obese. So instead of approaching those children as part of well child care visits, we restructured the care so that they were having what we call chronic disease management visits. We instructed the nurse practitioners and taught them how to do motivational interviewing. And then we tailored our intervention and our counseling of the nurse practitioners to the patients to the parents' readiness to change, stage of readiness to change. We had health system changes. I'm not sure why I put not applicable, but we did have health system changes and changes in body mass index and behavior, and had about 95% follow-up rate from baseline to 1 year and 2 years. STAR is ongoing. 14 pediatric practices. This is the 6 to 12-year-olds, 800 children, 1 year in duration. This was stimulus funding, and the idea wasn't to do a brand new intervention to test what worked for obesity. The idea was take what works and put it into, increase the uptake of it, of what works by clinicians and parents. And so what we are doing in STAR is point of care best practice alerts to clinicians, decision support tools to help the clinician know how to do the right thing when the patient comes in who is already obese. We're doing also to support the uptake of evidence among patients, we're doing text messaging, telephone coaching, and our outcomes are all point of care outcomes from the health system perspective, all HEDIS measures. And from individual level outcomes, we look at changes in body mass index in the children, changes in behavior by survey, and I'll come back to that. And our follow-up, we just completed all of our baseline assessments. So the use of electronic health records for recruitment. So in both of the trials, we use the EHR. Through a HIPAA waiver for recruitment, we get access to the minimum necessary personal health information. And from that, we identify pre-eligible participants. For example, in the STAR trial, we identified all children who are 5 to 12 years of age with a body mass index over the 95th percentile. Through the electronic health record, we're able to exclude specific ICD-9 codes if they have chronic health conditions that interfere with growth and weight. We exclude patients on the research do not contact list. And we send clinicians a list of their pre-eligible patients so that before we even get any information about the children who we could contact, they get to exclude families who they do not think would be appropriate for us to contact. Because pediatrics is very, it's somewhat different from medicine in that children come in for their well child care visits around their birthdays, which is perfect for a randomized controlled trial where we really need to target those well child care visits. They come yearly, and the no-show rates are pretty low actually in pediatrics for those physical exams. So we use weekly data polls of all upcoming appointments. So we identify from the children who we have in our pre-eligible list, we identify on a weekly basis who's coming in for a visit. And that triggers the research staff to begin our recruitment protocol. So we send letters describing the study, and these are patients who the clinicians have not opted out, describing the study, an opt-out telephone number for patients to opt out before we recruit them. For intervention delivery, our most recent intervention is using point-of-care alerts, or in EPIC language, best practice alerts. We use the best practice alerts to get clinicians to adhere to the HEDIS measures for body mass index diagnosis, nutrition and physical activity counseling. We use decision support tools such as SMART sets, again in EPIC language, to guide a clinician through evidence-informed recommendations for what to do with that patient when they come in for their visit. And then we've also started using electronic patient portals for communication with families and patients with our health educators. This is the example of the best practice alert that we use. It's a neon yellow sign that's a hard stop in the clinical workflow that basically tells clinician, your child who was measured today has a BMI over the 95th percentile. Click here to essentially follow the recommendations by the expert committee recommendations that came out in 2010. But we also are able, from the clinical decision support tools that we've created, to guide them in how to code for those HEDIS measures, what labs to order, how to follow up with that patient, do referrals, and also have them print patient instructions and an after-visit summary. I'll skip through some of the evaluation of this because I included it in the packet, but it works. And actually, some of our already, the point of care outcomes that we have from our STAR intervention shows that just a simple electronic best practice alert did change clinician practice. So we also use the electronic health record for outcome assessments. And this is where it's very important that the children come in for those visits on an annual basis. And we've used the electronic health record to get our point of care outcomes, the HEDIS codes, ICD-9 diagnosis codes, and clinical measures of body mass index. And I'll go through a little bit of the cons, risks, and trade-offs because all of those I've somewhat mentioned. So privacy, we talked about already. You do require HIPAA waiver of authorization to access minimal amount of information. And then IRBs, almost all IRBs will require written consent to access more detailed electronic health record outcomes. Some of the other challenges is that the programming code for the decision support tools are specific to the EHR vendor, which makes dissemination to other vendors. We work with Epic, but translating this to eClinicalWorks or NextGen, some of the other vendors, has proven to be difficult as we've worked with the CDC to do so. Alert fatigue. This is especially true with some of our best practice alerts with clinicians saying, we get so many of these and we don't know which ones to ignore, which ones are important. And it is something, the competing demands of clinicians to respond to these alerts is something that we always keep in mind. It's a substantial effort, regardless of what you design, to train and support clinicians in the use of any of these tools. And that we've heard loud and clear. And a lot of the effort and actually the money of our trials is to train the clinicians and support them through the use of some of our tools. Accuracy of height and weight measurements. We've done in-service training. It's very important to get good measurements of heights and weights in children, not that they shrink. And so you can't or you can't cut corners in not doing the training for especially height measurements, and that's expensive. Very careful not to interfere with clinical workflow. One of the things we're going to talk about are these patient-centered outcomes and whether clinicians should be doing those through surveys. Clinicians do not like interrupting their workflow for you to have a survey for data collection. It is not not feasible. And then I think finally the most important one is the difficulty in using the electronic health record to collect outcomes from non-discrete fields. So things like smoking, breastfeeding, behaviors are really difficult to collect from an electronic health record if they're not discrete fields, like height and weight. And will probably require, if we're going down that route, to do natural language processing or patient surveys, which gets pretty expensive when I have research staff who have to call 800 or more participants. So I'll end just with stakeholder engagement. We've done a lot of formative assessment and clinician interviews, make sure we get it right. They will not use any of our tools. They'll click away from it if we don't get it right. We do a lot of pilot testing. We've done a lot of, used a lot of methods for training busy clinicians, webinars, et cetera. And then we've engaged clinician champions at each of the practice sites. And in some of the work that, in the slides that you'll get at the end, you'll see some of the formative interviews that we've done with clinicians around this. And just to acknowledge my co-investigators and research staff in the obesity prevention program. Thank you.
Thanks, Elsie. That was a great overview. You've seen three totally different examples now of large, simple trials. And the fourth one, presented by Dr. Devereaux, we'll talk about the HOPE trial, which focused on a study that was done for some regulatory-based approval on prevention of major cardiovascular outcomes.
Thanks very much for the opportunity to present here today. One thing up front, need to tell you is that I was not involved in the HOPE trial. So I finished my cardiology training in June of 2000, and the trial was published in January of 2000.
So the pressure's on because I was.
I know, that's what I was going to point out, is that you were involved, so if I say anything really egregious, you'll have to cut me off. Salim Youssef was the PI of the trial, and I'm at the institution, and he asked me if I could present here today because he knows that I am actually a passionate believer in the value of large trials. And the 70% of my time when I'm not doing clinical cardiology, I am doing large clinical trials. So the aim of the HOPE trial was to look at the effect of ramipril versus placebo and also vitamin E versus placebo on a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. It was a blinded 2x2 factorial randomized controlled trial. The design was to include just over 9,500 patients, followed for 4 to 6 years. It was powered to detect a relative risk reduction of 12% in the primary composite endpoint. Key inclusion-exclusion criteria, patients just had to be age 55 or greater, have either demonstrated cardiovascular disease, that is coronary heart disease, peripheral vascular disease, or stroke, or have diabetes and a risk factor for coronary artery disease. Exclusion criteria, heart failure or low ejection fraction, or on an ACE inhibitor or vitamin E. So they were, in general, extremely simple and easy to implement. It shows the overall study organization. It included 267 centers in 19 countries throughout North America, South America, and Europe. There was national coordinators and regional coordinators, which were fundamental in terms of the conduct of the trial and been pretty consistent with the way that we've organized the trials through our institution. The project office was in Hamilton. There was an international steering committee and a data safety monitoring board, sub-study publication policy, and event adjudication committee. The primary funders of the trial was actually what is now the Canadian Institute of Health Research, but at the time was referred to as the Medical Research Council of Canada, Heart and Stroke Foundation of Ontario, and then there was also drug companies that were involved. The study was independently designed, organized, and conducted, analyzed and reported by the Canadian Cardiovascular Collaboration and the HOPE Steering Committee. It shows you the overall primary results. And as you can see here, there was a highly statistically significant reduction in the primary composite of cardiovascular death, MI, stroke, with ramipril, and for each one of the individual components of that primary composite. So a question we were asked to address here is, why is the HOPE trial a large, simple trial? Well, its large sample size, I think, and it's being well powered to address clearly these endpoints makes it a large trial. It had very broad, simple eligibility criteria that made it very easy to implement, both in terms of the trial, but also easy to implement for physicians afterwards in terms of their clinical practice and who they would apply the results to. It was a very simple intervention, just given once a day. And I do agree with the comment made earlier. I think so often in medicine we test things that are complicated, but the likelihood they'll ever be delivered that way in clinical practice is extremely unlikely. We have to test things that actually have application within our clinical management. The data collection was kept simple. There was 4 CRFs at the start of the trial. It took 20 minutes to collect. There was 2 pages at each follow-up visit, 10 minutes to collect, and then 4 pages at study closeout, 20 minutes to collect. The follow-up was kept simple. Patients were seen every 6 months in the trial, typically for an average of 5 years. The applicability and cost implications. So for applicability, I put forward that it is applicable. It had very broad, simple eligibility criteria. There was a total of 267 international centers involved, which once again enhances the applicability of the results. Also, I claim another fundamental reason why we want large international trials is that, as everyone is aware, knowledge translation is a big challenge. It's very difficult to actually get knowledge translation to happen. One of the few consistent signals with knowledge translation is having local opinion leaders buy into it. The best way to do that is to actually get them involved in the trial. And I'll show you data of that in a moment of how the results of the HOPE trial changed clinical practice in Canada very dramatically with all of the opinion leaders having been involved in the trial. It was a very simple intervention. In terms of simplification, once again, data collection and follow-up is kept simple. reporting was kept very simple in that only SUSARs were reported to regulators. The cost ended up costing $21 million plus drug and monitoring for this 9,000 plus patient trial for 5 years of follow-up, which in relation to a lot of other trials in our institution and other ones that we're involved with, it was actually very cheap. And remember, it was testing 2 drugs at once, which is also another effective way to keep down costs. Another important aspect of the trial was, in terms of its applicability, relates to whether or not we had complete follow-up. So the DSMB recommended early termination of the trial in March of 1999. The results were presented to investigators in April 1999. The closeout was completed in August, and then the database was then closed November 1st, 1999. Vital status ascertainment on 99.9% of patients. Non-fatal outcomes on 99.3% of patients. Adjudication complete on 99.9% of patients. The percentage of forms were clean in 99.4% of patients. Another issue that's really important to applicability is people have to have a belief that you actually have followed all the patients, because the problem is when we don't follow patients, we make things complicated, and that's one of the reasons why we lose patients, where interventions are complicated. Then you're not sure what happens to them, and people are less likely to believe in the results. This shows you the uptake of Ramipril in Ontario, Canada, where there was a lot of opinion leaders who were actually running the trial. And this is looking at the number of prescriptions for ACE inhibitors filled by patients age 65 or greater in Canada who are covered under our Medicare system. And this is per 100,000 patients. So the top line is showing you patients who are just overall ACE inhibitors. The red line is showing you Ramipril. And the vertical lines that are going up here are showing you from newspapers telling us that the trial was stopped early from the DSMB, to in the summer when the results were presented at the European Society of Cardiology, and then the electronic publication in New England in November, and then the print publication in New England in January. And as you can see, the purple line was enalapril, which was the most common ACE inhibitor. It was already coming down, but it definitely came down after that. And then Ramipril took over. And this shows you ACE inhibitors in diabetic patients who were a large portion of this trial, and showing you just after the HOPE trial results came out, Ramipril took over 70% of the market in terms of these drugs within Ontario. So once again, just speaking to the value of how we can influence clinical care by having large multi-center trials and having key opinion leaders involved in the conduct of those trials. In terms of risks and trade-offs, a risk at the time was that it was a factorial trial, and it's still a risk today that there's a lot of people who offer a lot of resistance to factorial trials and concerns about interactions. I think personally these are overwhelmingly misplaced in terms of a lot of people's perceptions and concerns about it. And in fact, I think we should ask ourselves the question, why in fact not every trial is a factorial trial? Trials are incredibly expensive. We should be actually we should be taking advantage of trials to test at least 2 interventions at once. This trial did only report SUSARs, which was very uncommon at the time. It's wonderful to see that the FDA has accepted that as a path forward in terms of reporting, but that was not the case at the time. The FDA did accept it, and it was approved prior to doing this trial. And the data collection was once again kept simple. Stakeholder engagement occurred by asking a very important clinically relevant question, by going international and by engaging friends and colleagues who had worked together in the past, which has been the general approach to undertaking the trials in our center. The infrastructure, there was 5 people who worked at the trial in our center. That was it. The bureaucracy, though, has dramatically increased since then. It's become overwhelmingly more complicated to do this, which is a big issue around the issue of simple, because it's a relative concept. What I might call my simple trials that I'm leading, others may look at it and say, in reality of what they envisioned, it's actually not simple. We have to push to make them a lot more simple than what they currently are. In terms of regulatory approval, the FDA did approve this at a time. I just want to point out that in a recent experience I've had with the FDA, I think it is true, and it's, I think, a consistent finding with our own institution that the FDA is actually very reasonable. What has become a lot more challenging has been the EU. But this is relevant also to America and to Canada. The reason is we want large international trials. The EU regulations become much more challenging in terms of getting through the process and what's being demanded and the cost implications as a result of that. Future directions, I think there's big issues around consent and follow-up. One trial John Eichelboom in our group is leading us in is a trial called INFORM. And it's looking at patients who need transfusion. There's a lot of debate right now about what are the effects of old blood versus new blood. And in this trial, we've been able to get consent waived. In other words, patients who are going to get blood, they're going to get blood. And there's a certain time period they can get the blood. So we're not going to offer them unusually long blood. It's just within the time frame of blood that's available. And in being able to waive consent in this trial, the trial in the first 6 months, just ramping up in the first 3 centers, was able to randomize 4,000 patients. The follow-up is being done through administrative databases to keep down costs. 24,000 patients will be randomized at a total cost of $2 million. It's incredibly efficient from my experience in a lot of trials that we're actually doing. Another trial in terms of applicability, consent, and cost is the PADIT cluster randomized control trial, which Stuart Conley in our group is leading. It's looking at an issue of antibiotics regimens to give patients when they're getting pacemaker insertions. And the current regimen is giving just a single dose of antibiotics, and we actually think that giving a more longer duration of antibiotics would be beneficial. To really know the applicability of that, you want the whole hospital system to change. And what we're doing is a cluster crossover. So the hospital for a 6-month period may be randomized to give the current strategy or convert to giving the actual more advanced strategy. In doing this, some of the centers have agreed to waive consent. Some haven't, which highlights once again the problem and inconsistency that exists within ethics and institution boards across our centers. In doing this approach of a cluster crossover compared to an individual patient randomized controlled trial, the cost has been cut by over half. And these are some of the directions of trials we're doing right now. Thanks very much.